Thank you for joining us for today's webinar. My name is Bahare Cloutier, and I'm the founder and the chair of the board for Spinal CSF League Canada. This webinar is part of our ongoing effort to provide valuable resources for patients, caregivers, and healthcare professionals alike. Now, it's my absolute pleasure to introduce tonight's moderator, Dr. Farnaz Amuzegar. Dr. Amuzegar is a clinical associate professor in the Department of Clinical Neurosciences at the University of Calgary. She practices as a neurologist and headache specialist at the Calgary Headache Assessment and Management Program. Her special interest in spontaneous intracranial hypotension has led her to spearhead educational, advocacy, and research initiatives to raise awareness and advance knowledge in this field. She also implemented the first SIH registry established in Calgary, which has now expanded to Toronto. Dr. Amuzegar is also a member of the Medical Advisory Board and serves as chair of the Scientific Committee for Spinal CSF League Canada. We are so grateful for her role and all her efforts. She has been instrumental in advancing our mission. I would also like to thank our esteemed speaker, Dr. Satish Raj, for sharing his time and expertise with us today. And with that, I'll hand it over to Dr. Amuzegar to formally introduce Dr. Raj and get us started. Thank you again, everyone, and I hope you enjoy the conference and the webinar.
Thank you, Bahare, for that kind introduction. I'd like to thank yourself and everyone at Spinal CSF League Canada for all the hard work and support in advancing education, research, and patient advocacy, and making webinars like this possible for us. Welcome everyone to this exciting webinar on postural orthostatic tachycardia syndrome. I'd just like to remind you to please submit any questions you have in the Q&A, and we will get to them at the end of the session today. So as Bahare mentioned, I'll be our moderator this evening, and it's my absolute pleasure to introduce our speaker for this evening, my wonderful colleague, Dr. Satish Raj. I've had the privilege of sharing several patients over the years with Dr. Raj and have learned a tremendous amount from him. Dr. Raj is a heart rhythm cardiologist. In 2014, he founded the Calgary Autonomic Investigation and Management Clinic, and he's currently the Director of Education at the Libin Cardiovascular Institute and Professor of Cardiac Sciences at the University of Calgary's Cummings School of Medicine. He runs an active human autonomic physiology research program with his primary research interests relating to understanding and improving treatment of conditions such as postural orthostatic tachycardia syndrome, POTS, which is what our webinar is about tonight, as well as other topics including vasovagal syncope, orthostatic hypotension, initial orthostatic hypotension, and now long COVID as well. So Dr. Raj will speak on POTS this evening, which is a very common comorbidity with SIH. So please take it away, Dr. Raj. Thank you so much for being here.
Well, thank you both for having me, and thanks for those of you who've joined and are planning on spending a bit of time with me this afternoon. If I can move my bar, I will. So if all is going according to plan, you will see my title slide here. And as Dr. Amuzegar pointed out, POTS is associated with many comorbidities, and certainly CSF leaks are among what we see. My disclosures are listed here. Nothing too specifically dealing with what we're going to be talking about today. I will point out one thing, and that is that there's a number of POTS-related consulting opportunities that are listed here. And actually, if I'd given this talk 10 years ago, none of those would be there. The fact is that for the most of my career, there's been very little to no interest from industry in POTS, but that's changing. And the promise that holds is that if we give this talk 10 years from now, we may have therapies that have actually evolved from these early consulting opportunities. It's reached a point where it's on the radar of big pharma and others that actually have the wherewithal to try and move us forward. So in terms of the discussion, I guess the first question is what is POTS? What are we dealing with? And the definitions we use today really haven't changed that much in 30 years. It was in 1993, a report came out of the Mayo Clinic by Ron Schondorf and Philip Lowe, Ron Schondorf was a fellow at the time. He's actually currently a senior neurologist at the Jewish General Hospital in Montreal, affiliated with McGill University, so a strong Canadian connection. But they described a cohort of patients that they didn't fit neatly into other diagnostic bins that they had. So this group of patients had an excessive increase in heart rate on standing, or an excessive orthostatic tachycardia. That was defined as an increase of greater than 30 beats per minute. Now, one of the challenges with orthostatic tachycardia is that it's physiologic, right? It's normal for the heart rate to go up when we stand up from a lying down position. And worse than that, or at least in terms of complexity, worse than that, is that the amount that it normally goes up varies with age. And in the very young, it goes up a lot. People can be very healthy and have huge increases. As we get older, it tends to go up less normally. So what they found is that there were a lot of kids actually that met the excessive orthostatic tachycardia criteria who were perfectly well. And so they went and did a detailed study, and I think using the schools in Rochester, Minnesota, and Olmsted County, and found this to be true. And then so the criteria have evolved from the beginning to more recently, where in kids age 12 to 19, so under 20, there has to be an increase of at least 40 beats per minute from lying to standing, and that has to occur within 10 minutes is the convention. And this has to occur in the absence of orthostatic hypotension, right? So a blood pressure, heart rate increase in the absence of a blood pressure drop. And that's not because it's unimportant if the blood pressure drops, it's because that's been recognized for well over 100 years as a significant problem in its own right. So they're trying to describe something new that hadn't been recognized. But everything I've set up to now, the orthostatic tachycardia, the lack of hypotension, that's physiology. That's POT, right? The key to POTS is the S, right? Is the symptoms or the syndrome, right? And syndrome basically means we have a bunch of people that are symptomatic, and these symptoms look like each other's symptoms. And the hope is that that can help us figure out how to approach patients in terms of treatment. Right? And the hallmark of symptoms, the specifics vary. We'll get into it in a little more detail. But the key is that a preponderance of symptoms have to be worse when they're upright and better when the patients lie down. Now, everything I've said now, the tachycardia, the symptoms, it turns out if one of us gets sick in the next couple of months with a bad cold or a flu, which, we live in Canada, chances are is going to happen, we will probably meet these criteria acutely when we're unwell, right? Most of us, when we're feeling that unwell, don't want to sit there and measure our heart rates or pay attention. But if you feel like, pulling out your inner scientist, do this. And I think you'll be surprised at how much of the criteria are met. The difference is that most of us will get better within a couple of days. These patients do not. Right? So it used to be that our requirement for chronicity was 6 months. It's evolved, and most people accept 3 months now, which, and truthfully, doesn't probably make that much difference, because I don't think that many patients get suddenly miraculously cured or better between 3 and 6 months. But we don't want to call all acute issues POTS, because there's a good chance if it's acute, it'll resolve when the acute insult gets better. The other caveat is that there are lots of secondary causes for orthostatic tachycardia, drugs, stimulants among them, but prolonged bed rest, severe dehydration. So all of this has to be in the absence of those things that can mimic it or cause the orthostatic tachycardia. Now, one of the challenges that we found a few years ago when the Canadian Cardiovascular Society was putting together a statement on POTS is that there was a lot of misdiagnosis. Some of it for the obvious reason that people just weren't aware of POTS and didn't think to diagnose it, but we were also aware of people that were diagnosed with POTS that did not meet criteria, that met one of the exclusions. And in some cases, many cases actually, it probably was an issue of physicians using a diagnosis of POTS to describe someone who's unwell, who had symptoms of orthostatic intolerance. So we see that on our little Cartesian plane here, had symptoms, but maybe didn't have as much excessive tachycardia as you need for diagnosis of POTS. So for POTS, you need lots of tachycardia and lots of symptoms. both worse upright. But what if you don't meet the heart rate criteria? Well, strictly speaking, before this, the correct answer was you don't have POTS. The challenge is that what a lot of patients hear when you say that is there's nothing wrong with you. And that is certainly not true in most cases. Something's going on. It just doesn't meet criteria for POTS. And so in recognition of this, we actually added to the nomenclature and tried to help create the ecosystem of orthostatic intolerance. And we came up with a grouping of something that we called postural symptoms without tachycardia, or PSWT. May not be the best name, but just describing that there's something going on, but it's not tachycardia related. The other thing that we realize is that while there are some patients that really just have a very focused cardiovascular phenomenon with the tachycardia and the symptoms, or similarly without the tachycardia, there's a larger group of patients that actually have significant other comorbidities. And certainly the CSF, spinal CSF leaks would fit into that, but it could be gastroparesis, it could be severe pain issues, severe migraines that are disabling. So not just they have other symptoms, but symptoms that are really driving their overall quality of life and well-being. And we thought it was important to characterize this because I think it seems obvious that, even if we were able to control the hemodynamics well with non-drug and drug treatments, if that's not what's driving their poor quality of life, we're not necessarily going to fix it. And so the criteria for this POTS plus that we came up with involved, it was vaguely defined, but basically something else of importance. And we list that here, and you'll see that CSF leak was on the list in our publication a few years ago. Now, we came up with a whole bunch of new terms, and some of the reviewers that were looking at this said, that's great, we're confused. Could you create a flow diagram of how to diagnose it? And so this slide's not here for anyone to sort of, remember it and paste it in their memory forever. The slide's here just to point out that by answering a series of yes or no questions, you could sort of work your way through the different diagnostic options that we came up with. And something like this this article is freely available, open access online. So this is something that someone could easily refer to if there were questions, if their providers had questions about where they fit into our Cartesian plane of orthostatic intolerance. So coming back to POTS, some of the common symptoms, more common symptoms, are listed here. And as a cardiologist by training, I've broken them down into symptoms that I could blame on the heart. But there are other symptoms that we see commonly that I have a lot of trouble blaming on the heart. And so they're listed here. On the ones in top on both groups in black are symptoms that are worse upright, right? Remember, that's a hallmark, is the patients with POTS have symptoms worse when they're upright, they get better when they lie down. But not all the symptoms are worse upright. So in the bottom in both categories, there are symptoms that are common: exercise intolerance, fatigue, ubiquitous, almost everyone has it. Sleep difficulties. We don't ask people to sleep upright, but the problem still occurs. So the point here is that, while the bulk of symptoms and certainly things driving quality of life are positional, not all symptoms are positional. So this is just a hemodynamic tracing to sort of show you what it is we're talking about. So this is data from a tilt test in a POTS patient on the right and a healthy control subject on the left. We show the heart rate channel on top, a blood pressure, continuous blood pressure channel in the middle, and then we had patients on a table that we tilted up. And so this just shows you the angle so you could see when the patient was upright and when they came back down to a horizontal position. So if you focus on the control subject first, the first thing to point out is the heart rate goes up on standing. So orthostatic tachycardia is normal. Our healthy control subject had it. If you then focus on the blood pressure and compare the control subject blood pressure and the POTS patient blood pressure, on average, they're not that different. I think if you were to look at the POTS tracing, you could look at it and say, that looks different. I mean, it's a lot spikier. It looks like I do when I wake up in the morning in desperate need of a haircut, where hair is just all over the place. And it turns out those spikes, I think, are actually important. And we're certainly doing work in our lab trying to understand what these fluctuations or oscillations are telling us. But in some way, this is a marker, I think, of distress, where the body's trying to maintain blood pressure and perfusion and struggling. But if you look at it, it's certainly not true, or it's, I think you can look at it and clearly see that the POTS patient average blood pressure is not lower than in the control subject. So it's not a disorder of orthostatic hypotension. And then finally, if you look at the heart rate channel in the POTS patient in the top right, like in the control subject, the heart rate went up with upright posture, but it went up a lot more, and it kept going up. So this particular participant was a POTS patient who didn't complete the tilt. The tilt was meant to be a 30-minute upright tilt, but she had to stop early because she felt unwell. And when she had to stop, her heart rate was almost 180 beats per minute. And all we had done is tilt her up. And as I mentioned, symptoms are important. So during that study, we actually were asking patients to rate their symptoms every 3 minutes. This was an early version of something that developed into the Vanderbilt Orthostatic Symptom Score. And if you look here, the control subjects in black, the healthy folks, basically were asymptomatic. Every once in a while, someone would get a little bit symptomatic, and then they'd pass out. So they'd drop out. But the POTS patients, on the other hand, were symptomatic early, and they remained symptomatic, and they got worse for the duration of the tilt. One interesting fact is that a higher proportion of the POTS patients survived or made it through the 30-minute tilt. Everyone survived the tilt, but a higher proportion of POTS patients made it through the full 30 minutes than our healthy control subjects, because more of the healthy control subjects fainted. Apologize for that. And the key message here is that POTS isn't fundamentally a fainting disorder. POTS is a feeling faint disorder. The patients felt like they're going to faint, and they told me they were going to faint, and they kept telling me for 30 minutes, while the healthy subjects, when they felt like they were going to faint, they fainted. So for years, I'd been studying patients with POTS, first at Vanderbilt University and then here. And we had a pretty good idea of the patients that we saw. But the question arose as to whether the patients that were coming from around the US and occasionally out from further out, to our research unit, or that went to Mayo, and they published a lot of stuff, whether they're really representative of the larger population out there, or whether this group was different in some way, sicker perhaps, more willing to travel to see physicians. And so in conjunction with Dysautonomia International, a large US-based POTS patient advocacy group, we created a study, an online study with ethics approval through Vanderbilt University, and largely disseminated through the social media platforms of Dysautonomia International. And this was an exhaustive, apparently not exhaustive enough, but quite an exhaustive, long online survey that really gave us a glimpse, a cross-sectional glimpse of what patients with POTS look like. So this was the first paper that came out from that work. There were, I think, about 5,000 patients that confirmed a physician diagnosis of POTS that had completed the survey at that time. We're up to about 10,000 now worldwide, although 90% are from the US. And what we found is similar to what we'd seen in our smaller studies. Over 90% of the patients with POTS are female, overwhelmingly white. Now, the reasons for this aren't clear. I will say that there is some bias in that the survey was only in English. And so certainly, for groups that don't speak English or people that don't speak English, they're more likely, they wouldn't have filled out the survey. And so it could be that we're missing or underrepresenting other races for language reasons. When we looked at the age of onset, what we found is the most common age of onset, or the mode, was 14 years old. But it's not that this occurs just in the young. If you look at the distribution, there's a long tail in adulthood. And in fact, just a little under half the patients actually develop their POTS above the age of 18. Right? So there's a big onset right around puberty, typically in young women or girls. But then there's a sort of another onset later on. And this may speak to the fact that these may be due to different causes. POTS is likely heterogeneous in terms of things that cause it. And that's actually one of the challenges in terms of coming up with targeted treatments. We had a laundry list of symptoms that we allow patients to either endorse or not. And the most common ones are listed here. And the top few are ones you'd expect for a disorder with tachycardia in the name. The tachycardia, ping, light-headedness, presyncope. But the next few that were almost as common aren't as obviously cardiac. Headache, very common, 90%. Difficulty concentrating, almost the same. Nausea, just a little less. Memory problems, pretty close, right? So the key message here is that while tachycardia is in the name and is certainly a dominant symptom and one that can be disabling and one that treatment does improve, POTS isn't just a cardiac disorder. POTS is a multi-system disorder with strong cardiovascular manifestations. What about quality of life? So some of this work was done in conjunction with Kanika Bagai, a sleep neurology colleague from Vanderbilt. And these aren't our data. We had done some work using the SF-36, which is a very generic health-related quality of life tool. It's not POTS specific at all. But one of the nice things about the SF-36 is that it's been studied in just about every disorder. And so what we have here are data that we just pulled from the literature on the quality of life scores using this tool reported with patients with chronic back pain in green and patients with end-stage renal disease on hemodialysis in purple. And the SF-36 breaks the scores down into a physical health domain and a mental health domain. And you can see the scores not great. And what we've done here is just superimpose the scores that we found in our POTS patients. So their quality of life is comparable to patients on dialysis. Right? So this doesn't speak to why, it doesn't speak to the issues of what to do about it, but their self-reported quality of life, and all quality of life is self-reported, is very poor. So one question that's come up in the past quite frequently is POTS a psychiatric disorder? And really the question that a lot of people are asking is POTS patients crazy? So there was a study we did at Vanderbilt. It was actually led by my wife, who before she did her psychiatry training clinically, actually was a research fellow in psychiatry at Vanderbilt. And we took patients that had come into our research unit and they went through formal structured interviews to try to map their symptoms to diagnoses in the DSM-4-TR. So the DSM is the Diagnostic and Statistical Manual, is sort of the psychiatry diagnostic Bible. I think they're on version 5-TR right now, so it's a few years back. And the short version was, there were some POTS patients that had depression and anxiety disorders, but no more than the general population, right? So, which is probably the correct framework for comparison, right? If we go to our heart function clinic and look at heart failure patients, right, some of them are going to have major depression and anxiety, right? So but certainly nothing to say POTS is associated with one of these disorders. They administered a series of different psychometric tests. One of the things that they looked at was anxiety using a couple of tools. And this actually is sort of an important point to consider. If you look at the POTS patient score here, they were in I think the mild to moderate, mild anxiety range using the anxiety sensitivity index here and compared to normals in black. But the question when you see stuff like this is that the right comparison? So my wife very happily pointed out to me that I would not have qualified as normal. Right, so to be normal, they actually screened patients psychiatrically, and you had to be uber normal. And that's probably not a fair comparison, right? Most of Canada and the US aren't. So in fact, if you look at data for the general population, this was US population data. Overall, their anxiety as a society was a little worse than what we saw in our POTS patients, certainly not statistically different. The POTS patients were not more anxious than the general population, but they were more anxious than the normal controls, the uber normal controls. So when you read the literature, just be careful to understand what the comparison groups are. The one really interesting thing that did come out of the study was they looked at inattention using the Conners Adult ADHD Rating Scale, or the CARS. And what they found was the POTS patients had more inattention than the normal control, but we know to be wary of that. But they actually had more inattention than the background general population as well. Not as much as the ADHD group. There was a third control group with ADHD. But this got us thinking because we knew POTS patients would complain about memory problems. We didn't understand it. But this raised the specter that maybe not all of the issue was memory. Some of it may be issues with attention and concentration and processing of the memories. But this led to some further work with neuropsychiatric testing to better understand this issue. Still an area that I think we understand poorly. Okay, so someone's diagnosed with POTS, then what? What do we do about it? So in terms of basic testing, there aren't a whole lot that are, routinely recommended. The key is actually a good evaluation clinically. And so I wrote history and physical examination here. Just to be clear, that's history, more history, still a bit more history, and then a bit of exam, right? A lot of this is trying to understand the journey and what happened and put that together. And so these visits are not short visits, certainly not the first one, but even follow-up visits tend to take time. And that's one of the challenges. The key to a physical examination is a good set of orthostatic vital signs. And then you want to rule out some other things. In the specific cases, you'll target more things, but you can't make a diagnosis of a postural disorder without measuring heart rates and blood pressures posturally, lying and standing. In the case of POTS, you have up to 10 minutes. In terms of blood work, the Canadian Cardiovascular Society recommends some very basic blood work just to make sure you're not anemic, to make sure there's not a major electrolyte disturbance, to make sure that you're not hyperthyroid, which can certainly cause a tachycardia. It wasn't in the document, but I'd consider getting a cortisol level as well, just to make sure your adrenal gland hasn't totally failed. Just to be clear, I'm not talking about subtle adrenal abnormalities. What you want to avoid missing, what you don't want to miss, is total adrenal failure, which can certainly cause severe dehydration, a vascular problem that can lead to tachycardia, among other things. There are a bunch of other tests that we'll sometimes do shown down below, but really the secondary testing is driven by, and there are tests not here that fall into this category, but driven by the initial evaluation, that initial history and physical exam. In terms of treatment, there's a layer of non-pharmacological treatment approaches that we use for everyone. And then we tier drugs on top of it as needed. And the principles are listed here, increase in dietary salt and water intake, the use of compression garments, and an aerobic exercise program. And we'll talk about each a little bit. So historically, I think patients have been told by physicians forever, with these disorders to take more salt. But it turns out until very recently, there's actually almost no data that it helped. My last grant that I had when I was at Vanderbilt actually had a dietary salt study built into it. It was a study where we brought patients into Vanderbilt, brought healthy controls as well, all female, premenopausal, and we brought them in twice, one about a month apart, so trying to get the same phase of their menstrual cycle. And once we brought them in and put them on a very high salt diet, and then another time brought them in and put them on a very low salt diet. So brought them in for a week. For the first 6 days, we did nothing but feed them, right? We want to get them into balance and let the physiology adapt. And then we studied them. And what we studied was actually things like, the whole idea of salt is that you retain fluid and you expand the blood volume. We measured that. And it turns out it worked. And then, we decided to stand them up and see what happened to their heart rate and looked at, collected blood to look at the norepinephrine levels, which is the neurotransmitter in the sympathetic nervous system that we thought drives the heart rate. And again, what we found is that in the patients on the high sodium diet compared to on the low sodium diet, same patients, that the blood volume increased and the norepinephrine levels on standing, it's incorrect. It says it went down here. It just went up by less. And similarly, the heart rate then on standing didn't go up by as much. So in other words, high salt diets work. So this is actually how we do it in clinic. So I try and get all my patients to drink at least 3 liters of water a day. And realistically, that's a lot. It's absolutely doable. I try and get patients to have a water bottle, not like I do. If you go to my kitchen and open one of the bottom drawers, it's full of water bottles, right? The key here is not to have 10 water bottles, but to have one. And I want them to have it with them all the time. I tell them that, just like, if you take a picture of someone that wears glasses, their glasses are going to be in the picture. If they go for a family portrait, I tell them I want them, their partner, their kids, if they have them, in the water bottle in the picture, right? It should be with them all the time. If they come to clinic, I ask to see the water bottle. And if they say they left it in the car, that's a fail. And this may sound crazy, but having it around and available all the time is actually one of the keys to success. And then for salt, we want them to get about 10 grams a day. I think there are two professional statements that have opined on this. One recommends 8 to 10 grams, one recommends 10 to 12 grams. So we settle on about 10 grams. The problem is counting. I don't know how to count that. I couldn't do it, and I can't advise patients to do it. And so what we went with is that a teaspoon of salt is about 5 grams. And so 10 grams means you need to get about 2 teaspoons. Now, realistically, one could argue teaspoons, it's actually a measure, but most people just grab what they have in the kitchen. So you can have slightly different size spoons and stuff like that. Fair enough. The goal, this is a horseshoes and hand grenades sort of thing. We want to get close. We don't have to be perfect. And so the approach I've taken is what I call the Ziploc bag approach. In the morning, I'll ask patients to take the 2 teaspoons and put it in a Ziploc bag or a Glad bag or some other container. And through the day, add salt to their food and drink if needed from that container and not just randomly shaking things on. So they'll get an idea of how much they're getting in, and they'll have a pretty good idea if they're getting in what the target dose is. Most patients like the taste of salt, and if so, the cheapest and most effective way to do this is just to add salt to foods. But some don't. And so I have some patients that will add it to water, some younger patients that add 1/3 of a teaspoon of salt into a shot glass and do saltwater shots with water, sort of like a margarita without, the alcohol. It doesn't really matter to me how they do it. They need to get in the salt, they need to get in the water. It doesn't have to be together. It can be together. I don't tend to use salt tablets very often. The only advantage of salt tablets are you don't have to taste it all. So if you really don't like the taste, it's an option. The downside is the regular salt tablets often aren't well tolerated. I think they cause a lot of nausea, worse than table salt. There are coated salt tablets. One is a brand called Vitasium. They tend to be better tolerated, but it can get expensive because you have to go through a lot of tablets if that's your only source of sodium. What about compression garments? So a few years back, one of my PhD students did a compression study, and what we showed is that lower body compression, so from the abdomen down, it helped. So we had patients do repeated tilt tests on one morning with compression, without compression. You can see here that with compression, the heart rate still goes up with tilt, but then it plateaus. While without compression, it goes up more, and then it keeps climbing. And in fact, we didn't do just 2, we did 4 interventions. We looked at the full compression and no compression that I showed you, but we also looked at sort of an abdominal compression, which was sort of an abdomen pelvis, so bicycle shorts sort of a configuration. And we looked at calf compression, leg-only compression. So leg was actually calf. And you can see that the abdominal compression is almost as good as full compression. And the leg compression is almost as useless as no compression. And what we found is that the symptoms decreased in a dose-dependent manner when the patients were tilted, depending on how much compression they had. And the symptoms actually related to how high their heart rates went. So this was a proof of concept study using, these ugly garments that, no one would wear. But just recently, earlier this year, Kate published a follow-up study using commercial garments. So what we often recommend are having patients go to a sporting goods store and purchase triathlon tights. And the higher end tights will actually give you a compression rating of between 15 and 18 millimeters of mercury, right? The key is the high-waisted tights, and that worked too. And there's a follow-up paper that is about to be submitted looking at a focus on abdominal and pelvic compression using things like compression bicycle shorts or Spanx, body shaping garments like Spanx. And they work not quite as well as the full-on tights, but they work as well, right? So compression both works in the lab, but it actually works importantly in the home and in the community. And finally, a few words about exercise. It was one of those things that was always recommended in the good thing to do category. But it wasn't until about 15 years ago that some colleagues in Dallas published a study, which was a before and after study design, where they found that patients that completed a 3 to 6 month exercise program, patients with POTS, got better. And they showed increased fitness levels, increased blood volume directly measured, increased cardiac mass. So they did cardiac MRIs, as well. They put needles in nerves and looked at nerve activity and it fixed that. All stuff I find really cool, but I'm a human physiology nerd, right? Most patients don't care about these things. But they showed that this exercise training decreased the heart rate increase on standing. So patients care a little about that. They can measure it. And importantly, it improved the quality of life. So these guys also use the SF-36 that I showed you earlier. Now, from a practical point of view, this is how they do it. And it's not an easy thing to do. A couple of keys. In terms of the effective exercise in POTS, really, we're talking about aerobic training, right? So I have patients that tell me they are doing yoga or they're doing Pilates. And don't get me wrong, I actually struggled when I've tried to do Pilates. It's very hard and probably very good for you in terms of core strengthening, but it's not a replacement, right? In terms of the POTS aerobic training, you can do that as an and, but not as an or. In the study, if you know the patients were all skin and bones, they recommended a little resistance training for the thigh muscles because you need a little bit of muscle bulk that acts as a fluid reservoir. But it's mainly about aerobic training, not about resistance training. The exercise for this aerobic training effect needs to be regular, so at least every other day, so 4 times a week. I often will try and get patients to try for 5 or 6 just because you're going to miss days here or there. And fairly quickly, we try and get patients to get to 30-minute sessions. In the study, they had calendars and exercise physiology people and trainers. The truth is, I don't have any of that, right? So I try and give patients the principles and let them figure out how that can work best into their life. Now, the most important and clever thing they did is that initially they banned upright exercise. And the reason is because when you tell people to go and exercise and then you ask them, well, what are they going to do? Typically, it's going for walks or treadmills or those evil elliptical things, all things where you're upright. And, if you think about it, if your heart rate is already 140 or 150 beats a minute when you stand up before you turn the treadmill on, you're not going to be able to last very long. So they said, why waste the heart rate on gravity? Save that and invest it in the exercise. So in the study, their preferred exercise modality was the rowing machine. Lots of different reasons for that. But one of the benefits is that you're squatted down and small from a gravity point of view. If that didn't work out, the other options were a recumbent cycle, so the cycles where you're sort of leaning back, or swimming. Now, realistically, this study was done in Texas. I suspect every other person has a backyard pool, right? So swimming is easily accessible. I live in Calgary, right? We get excited when the temperature is just below freezing in the winter, right? I mean, that's the one advantage of when it's minus 20 is you start getting cold and shivering. And when it gets up to -2 or -3, we get excited. Outdoor swimming pools here we call ice rinks, right? So swimming is not a viable option for most of my patients. We don't have enough access to indoor pools. So most of my patients will use a rowing machine or a recumbent cycle as their modality. And this final point is critically important. When I first started, advising patients on exercise based on this study, I'd have patients come back to me and say, Dr. Raj, I tried this and it's just not for me. It didn't work. And so I actually contacted Dr. Fu, who's the first author on this paper and a friend, and said, what am I doing wrong? And she said, well, we said everyone got better. We didn't say it happened right away. Right? And it was a 3 to 6 month program. So they did a before and after evaluation. And what I learned is that it can take up to 6 weeks before patients start to notice any improvement with exercise. And that's longer than I would give it if someone told me to exercise and you'll notice improvement, right? Without being told that it does take that long. It seems like it takes longer than it seems like it should. But we've been doing this now for quite some time. And once people start to notice the benefit, instead of struggling with the exercise, they actually feel worse, not when they exercise, but feel worse if they miss days of exercise. But that initial slog can be tough, right? There's a light at the end of the tunnel, but it's a long, long tunnel. In terms of pharmacological treatment approaches, there are many listed here. Some focus on blood volume expansion with saline or DDAVP or desmopressin. Some focused on blood pressure or squishing of the arteries or veins, mitidrine. Some focused on lowering the heart rate. And the one in red here, I'll touch on this, but to be clear, red is do not do, and we'll get to why. So saline, so blood volume expansion, acutely fixes things or improves them greatly. And you can see that here on the far right, basically after a liter of saline, an hour later, the heart rate, the orthostatic tachycardia was cut in half and well into the normal range. It's very effective acutely. And so if someone's in acute distress, it's a reasonable, and they're in the emergency room, I would argue it's almost always a reasonable thing to try. Having said that, it's not a great chronic treatment. And the reason is how you get the saline in, right? If you're doing it just once or twice, you can just put an IV in the arm and it'll work. But if you start doing this regularly, weekly, multiple times a week, it won't take too long to where you'll have trouble getting IVs. And then you have to start putting in long-term catheters, PICC lines, and then eventually portacaths or long-term central lines. And the concern is actually the long-term central line. They have risks of infections, clots, and other life-threatening complications. And so we try to avoid that. Regular long-term saline is considered a do not do by both the Heart Rhythm Society and the Canadian Cardiovascular Society recommendations. DDAVP is a drug called desmopressin. It's a synthetic version of a hormone that tells your kidney to hold on to fluid, hold on to free water. And so we showed several years ago that DDAVP, 0.2 milligrams, with half a liter of water, it lowered heart rate. You took the fluid, you held on to the fluid, and that helped. I don't use this very often. When I do, I typically use it as a special event drug, right? So someone wants to go to a movie on Thursday night, they're not sure how they'll feel because it's only Monday. If you take the desmopressin that afternoon, chances are you'll feel okay, right? So it helps you at that time. The challenge or the risks with this medication are that, on the one hand, it can't be that bad because we use a drug like this or this drug in 5-year-old boys who wet their bed, right? And we're not going to give 5-year-old boys who wet their bed something that's life-threatening. Except we don't tell 5-year-old boys who wet their bed to drink 3 or 4 liters of water a day. And so if you're taking this drug and retaining and taking in the water, you could actually get to the point where you dilute out your sodium, and that can be life-threatening. Now, one of my colleagues in Ohio had a program where he had a bunch of patients taking 0.2 milligrams nightly, and he would have them check a standing requisition to check their lab work weekly. And what he told me is that basically, as long as people stuck to the one tablet of 0.2 milligrams daily, everyone was fine. But one patient, found that it was so helpful that she thought if 1 is good, 4 is better. And she ran into problems. So it's not that you should be living deathly in fear of this drug, but you have to be careful and respectful and do a bit of monitoring and not overdo it. Midodrine is a blood pressure drug unlike any other. It's a squisher. It squishes arteries and it squishes veins. And there's not great data, but this is from the same study from Jairus Jacob, from the saline study, but you can see that an hour or two after the midodrine, the heart rate dropped a little. Not nearly as much as the saline, but it decreased, so it did have an effect on lowering heart rate. Beta blockers, these are the drugs that end in all. Lower heart rate. And as a cardiologist, we use lots of it after a heart attack. You have a problem where the heart rate's high and we can lower it, great. But lots of patients say they don't tolerate it. And the challenge is that at some level it sort of makes sense because the heart rate in most cases we think is due to another problem, specifically not enough blood coming back to the heart, which is why we want to increase salt and water and use compression and things like that. So lowering the heart rate without fixing the other things could make things worse. But what we found is if the heart rate's really high, in and of itself, that becomes a problem. So maybe it's helpful. So when we tested this, and this was at Vanderbilt as well, we found that propranolol, even in patients that told me they didn't tolerate beta blockers, when we gave a low dose of propranolol, that the standing heart rate improved, the orthostatic tachycardia improved, and symptoms improved. Right, so the question was why? Why did all these patients come and tell me that they don't tolerate beta blockers, and yet they did great on them? And it was actually Bonnie Black, our research nurse, who had a great clinical experience, who said, well, maybe it's because we use a low dose, because our patients tend to be sensitive to drugs, so we use a low dose of everything. And so then we tested that. We tested the lower dose propranolol against a fuller dose. And what we found is that the symptoms started to get worse again. So the key to using beta blockers, in particular, propranolol has been my go-to, is to use just a little bit of it, just a low dose. More is not better. More recently, there's a drug called ivabradine that's on the market. It's a funny channel blocker. It's approved for heart failure. But it's been shown by Pam Taub and her group in San Diego to also improve lower heart rate and improve symptoms, quality of life in patients with POTS. We're actually doing a study here in Calgary that's a crossover comparative effectiveness study. So we're comparing ivabradine to propranolol to placebo. Most of those approaches, like beta blockers, are blocking the adrenaline part or the sympathetic nervous system part. But we said, well, can we lower heart rate in other ways? And so we looked at seeing if we could augment a natural neurotransmitter in the body called acetylcholine. And we did that using a drug called pyridostigmine, or mestinon is the other name for it, that slows down the breakdown of this neurotransmitter. And we found it worked. It actually lowered the heart rate and improved symptoms. Now, the truth is this worked better in a lab setting than in real life, but it is something that can be used as an adjunct. The truth is beta blockers are better than this, but it can be used in combination with propranolol. And finally, I did say I'd come back to this, norepinephrine transport inhibitors. So there's a whole backstory to this we can get into at some point, but the important part is this is the only drug that we tested. It was a drug called atomoxetine, or Strattera. It's an ADHD drug. The only drug that we tested that actually increased the standing heart rate and increased the seated heart rate, that worsened the orthostatic tachycardia and worsened symptoms. Even placebo usually had a slight improvement in symptoms because of the way we designed the study. So in fairness, not everyone got worse with atomoxetine. About 2/3 of the patients we studied got worse. Some had no change and a few improved, right? Everyone's a bit different, but as a general rule, patients should probably avoid drugs that block the norepinephrine transporter. Now, realistically, that's most commonly found in drugs that are in this SNRI drug class, because the N is norepinephrine. It stands for serotonin norepinephrine reuptake inhibitors. So they can be a challenge and even harmful. And finally, just about a year ago, a little under a year ago, there was the first, or a paper, not the first, probably the best study so far, looking at transdermal vagal nerve stimulation. They use stimulation of the tragus branch of the vagal nerve in the ear with a sham, so active and sham study, and showed that after 2 months, I believe, of stimulation, that the heart rate decreased, that the orthostatic tachycardia decreased in this group. They didn't show that symptoms changed. So there's actually, this is an initial proof of concept study. There's a follow-up grant that's been submitted that we're involved with, along with Dr. Stavrakis, to try to conduct a larger study to try and see if this is actually going to be a useful treatment in POTS. The reasons for it are also unclear. We know that vagal nerve stimulation may have some effects on calming or settling down inflammation, and that might be the mechanism, but that's all speculative right now. So I'm going to stop there and leave you with these take-home messages that POTS is a chronic disorder. It's associated with a significant amount of disability. Importantly, it's a syndrome. It's not one disease. There are multiple pathways to get there, and they vary from individual to individual. The principles of treatment involve a foundation of aerobic exercise, blood volume expansion, heart rate control. And the final point that I didn't talk about, but I think is important, is that every one of our patients has a chronic illness, and often didn't before they got sick. And you could have two patients with very similar physiologies, but their ability to function and cope and their quality of life can vary greatly. And a big determinant of that is actually their learning to live or cope with having a chronic illness. And there are different approaches to that. I had a patient that taught me this, that went on sertraline or Zoloft and found it was very helpful to her. Some patients use those adult coloring books for mindfulness, and that helps them. Some people seek religion. I'm not suggesting that one approach is better than the other, but just as physicians, as caregivers, and as patients, we just need to recognize this is an issue. This isn't a mind versus body thing. This, we need to target all of these approaches to help patients live their best life. So with that, I'm happy to answer any questions.
Thank you very much, Dr. Raj, for an excellent overview of POTS. We do have some questions in the Q&A, so I can just start with the first one here. Someone's asking about POTS and CSF leak and whether the same concepts would apply to orthostatic hypotension and a CSF leak.
Similar, right? I would say I suspect the answer is yes. The caveat is in orthostatic hypotension, there are, I guess, different flavors. In patients that have autonomic nerve damage and orthostatic hypotension, these, are typically patients with, older patients with Parkinson's or other movement disorders, or patients that have had diabetes for a long time that's poorly controlled and are complications. In patients like that, I think, the tachycardia might be less of an issue, and we need to probably get more aggressive on drugs to support blood pressure more. But I suspect in most of the patients with the CSF, spinal CSF leaks that get hypotension, I think their blood volume is probably just really low, and I'd suspect their heart rates would be very high. And so I'd say yes, these are the similar approaches that we'd use in that group.
Sounds great. Another question is in terms of getting a provider to understand that a patient can have negative imaging for, I guess, a leak in this case in particular, but still potentially have POTS. Any resources that you would direct them to in terms of, I guess, specifically the POTS portion?
Yeah, so, the issue of physician education, what I'll say is that, any physician education is difficult, right? I mean, for any disorder. But it's happening, right? And this, in a pathological way, this is the COVID dividend, right? COVID devastated the world in so many ways and devastated many individuals. And, certainly this whole long COVID phenomenon has left some people quite disabled. But what it did do is actually crystallize a focus on some chronic illnesses, including POTS, in the lay press, right? I mean, so New York Times, the New Yorker, the Wall Street Journal, places that would never, acknowledge that POTS existed before suddenly would have it in articles. And so I think there may be some downstream benefits over time from this recognition. But in terms of specific resources about the POTS, Dysautonomia International, there's several groups, but Dysautonomia International has a website. They're in the process of upgrading it, but there are useful resources there. There's a group out of the United Kingdom called POTS UK. It's not POTSUck, it turns out, it's POTS UK, that has some resources. We have some on our University of Calgary website. If you sort of search Calgary Autonomic, we have some resources there, right? And it may be a matter of either printing stuff out and taking it to physicians. I wouldn't take a book. Physicians don't have time in that 10 or 15-minute clinic visit to read a lot, but something to indicate that this isn't just stuff you made up, but others made it up. I thought what the question was going to be is, not about POTS, but in terms of the issue of the CSF leak, that the imaging is negative, and how do you convince them that there could still be a leak? And quite frankly, Dr. Muzigar, you're probably in a better position to discuss this, right? But imaging can be difficult for that problem in and of itself, where it can be hard to find and it can be intermittent, and obviously, a lot of findings related to leak these leaks are gravitational and are more obvious in theory vertically than horizontally. But most of our good imaging tools, at least in Calgary, require you to be horizontal, right? In theory, there are MRI scanners that are vertical. I don't believe we have one in the province of Alberta. So separate challenge, maybe your next webinar.
Yes, definitely. That is definitely a challenge, and we do not have upright MRIs in Alberta. There is one in BC. However, our radiologists tell me that it actually doesn't have very high quality images. So at this point, it's not reached the same level as the regular routine MRIs. But we have several steps that we go through to identify patients with CSF leaks, similar to what you said. A significant portion of that is the clinical history, the examination, other neurological symptoms that they may have. And then we put all the imaging together, which includes MR brain, MR spine, and then we have our myelography or invasive types of imaging as well. So it's really just putting all the pieces of the puzzle together and also looking at other potential causes that could be comorbid. But it is definitely a challenge for sure. Now, the next question is about if you have a standard medication protocol or approach that you take with medications, because some patients apparently have tried different medications, but maybe it's not working. So do you have a sort of a standard protocol that you use and start something first and then add on others?
Yeah, it can vary a bit. I will say that the non-pharmacological approaches I take are the foundation for everyone, regardless. And it's to the extent that it's doable, it takes reinforcement, right? Exercise is notoriously difficult, not because patients have POTS. It's notoriously difficult in every medical condition whatsoever, right? It's just a hard thing to do. Compression can be difficult in terms of doing it properly and tolerating it. And so reinforce. In terms of drugs, I guess, my approach, and this is based on just what I do, not based on great data that you should use something first and this second, is that if someone's heart rate's really high, right? So on standing, the heart rate's 130, 140, 150, almost always they will feel better if you can take the edge off that. And the key is to take the edge off that, not to correct it, right? So if you can take that 130 and make it 110 or 115, it's still high, and still probably abnormal, but it can make a huge difference in how someone feels, right? And often my go-to drug traditionally has been low dose propranolol, so propranolol 10 milligrams up to 4 times a day, because short-acting regular propranolol only works for about 4 hours at a time. It's a short-acting drug, so dose it frequently, and people vary. So some people, their symptoms are worse in the morning and really not bad later in the day, so they may only need 1 or 2 doses early in the day. Other people may need it more. With the propranolol, you can also take extra doses. If you have bad asthma, or some people just don't tolerate the propranolol because of other off-target side effects, ivabradine a newer option. And like I said, we're trying to determine now if one is systemically better than the other. One downside of ivabradine, it's fairly well tolerated, but it is not always covered by insurance. It's not generic yet. It should be going generic soon. But it can cost about $85 a month here in Calgary if you don't have insurance coverage. And so it's, for some people that's not a big deal, and for other people that's prohibitive, right? So it's another option. On the other hand, if someone's heart rate's not going really high, let's say it's peaking around 100, 105, and their blood pressure is on the lower side, their top number in the pressures in the 90s or just around 100, they may benefit from mitidrine, the drug that I said was a squisher drug. And so that also, and it's an accident that's the case, that also is a short-acting drug that works for about 4 hours at a time, right? And so we would dose that typically 3 times a day, maybe at 8, noon, and 4, because we don't want people to lie down after taking the drug because they don't have problems lying down, right? We don't want to cause hypertension. We want to treat them when they're going to be vertical, right? So we don't typically use it around bedtime. Those are probably my starting go-tos. Now, if the one other one I'll mention is the mestinon or the pyridostigmine. I mentioned it's not a brilliant drug, but it can help a little. Most people tolerate it. And in fact, Blair Grubb, this guy in Toledo that has a large clinic, he actually gave it to a whole bunch of patients and then did a clinic data dump and had about 300 patients in a cohort that he reported. And a little over half thought they were doing better on it in a vague way. It wasn't a formal study, it was a clinic dump. But about 20% had to stop the drug because they didn't tolerate it. And almost all of it was due to abdominal cramping and diarrhea. Right? So if someone is prone to diarrhea already, I don't even consider it. But if someone is prone to constipation, and we see the spectrum in POTS, if someone tends to be very constipated, it's worth trying because it may help the heart rate and it may help the constipation. And so we'll often try that.
Sounds great. We are at time, Dr. Raj, but if you have a few more minutes, we could go through a few more questions.
Sure.
Yeah, sounds good. There's another question about association of menstrual cycle or menstruation with POTS and whether you've seen that, as well as iron deficiency.
Yeah, so I'm not sure about association with POTS. I mean, if the question is, do symptoms get worse, with the menstrual cycle, the answer is absolutely.
Mhm.
Um, it's worse right around menstruation and better mid-cycle. Years ago, when we were at Vanderbilt, we actually did a questionnaire survey, very crudely, rudimentary, where we just had 4 phases of the menstrual cycle, menstrual, premenstrual, and follicular and early and late follicular, right? So different phases, and just asked both patients and healthy controls to give a rating with an arbitrary scale of lightheadedness at different phases of the menstrual cycle. And it was worse right at menstruation and best mid-cycle. But the interesting thing is, if you look at the graph, if you graph that, the pattern was identical between the POTS patients and the healthy volunteers, the healthy controls. The amplitude was higher, right? At every phase, the POTS patients were more lightheaded than the healthy control subjects. But the fact that the lightheadedness was worse during menstruation and better mid-cycle was exactly the same. So, one of the, if it's, and patients will routinely complain about this, and one of the strategies that patients have used, some have gone to a Mirena IUD to try and avoid having periods. Um, there's I'm far from a birth control expert, but there's one called Seasonal that encourages breakthrough bleeds instead of every month, it's either every 3 months or every 4 months. So it doesn't solve the problem, it just makes it less frequent. But those approaches absolutely have been used. The other question had to do with anemia, was it? Or iron deficiency?
Iron deficiency.
Yeah, so the reasons aren't clear, but there is a reasonable amount of iron deficiency, and in fact, some of our patients will have very low levels of ferritin, which is a sort of a measure of iron stores. Um, and we do recommend treatment. Exactly what that does in terms of the tachycardia stuff is less clear. But Dr. Kanika Bagai, who worked with us on the quality of life stuff, it was part of a larger study looking at some other sleep issues. And she tells me, although I don't understand why, or nor do I understand the data, that you know uh, some of these POTS patients that have sleep issues, it may be restless leg syndrome, and iron supplementation is actually one of the treatments for restless leg syndrome. And so we recommend it if it's tolerated, because it may help with the sleep issues that almost all our patients have.
Right. Okay. And just to go back to the menstruation, I think the other part of that question was also if menarche, so start of menstrual cycles for females in particular, because you had mentioned that graph with the age being 14 kind of being the common age for this to start. Is there a relationship there?
Yeah, I don't know if it's related to the menstruation or, certainly that timing, in a hand wavy sort of way makes one wonder if hormones are playing a strong role in this. And I can give you a definite maybe, right? I mean, there hasn't been great studies looking at the hormonal effects, on this. The exact reason, I mean, there's clearly a huge female predominance, right? Huge. But it's not clear why, right? So one explanation may have to do with cardiac mass and size and things like that, but it's certainly possible that some of the hormonal effects are playing a role as well.
For sure. And there's a female preponderance in this condition, so one would
Yeah.
speculate
Overwhelming.
that there is likely, yes. And a question that had been sent in previously that's not on the list here right now was just the day-to-day fluctuations that occur and why that might be the case in patients with POTS.
Yeah, I mean, I think, it's life, right? I mean, there are day-to-day fluctuations in lots of things. I mean, I think, if we want to sort of be specific about POTS, I suspect that day-to-day our volume status, blood volume status isn't the same, either because we're not taking in the same amount or because we lose different amounts, right? Based on things as innocuous as weather. Patients tend to be very heat sensitive, right? So certainly, you go to the extremes of you end up on a Caribbean cruise, it's excessively hot and you don't do well. But even on a milder level, I suspect some of that is going to affect patients. Um, if you get an inflammatory response, that will tend to vasodilate you as well and sort of, stress the cardiovascular system. And some people listening, maybe not the patients, maybe their family, their partners are saying, well, but those are things that apply to everyone. But you have to remember that our patients, have a lowish blood volume and are depleted and basically probably don't have as much reserve. While if you're sort of, in your sweet spot, you have a bit of reserve to deal with this and you don't notice it. Well, if you're sort of teetering on the edge of symptoms, if it goes the wrong way, you become symptomatic and it becomes more obvious. Right. So, I mean, some stuff you can't do anything about. I mean, I tell patients, promise not to get sick like Mr. Bean did when he was running for office, but it's not practical. But you can strongly encourage patients to make sure they're getting in lots of fluid and salt and controlling the things that they can control.
For sure. Yeah, sounds good. And then there's a question about connective tissue disorders, particularly here, Ehlers-Danlos syndrome, and if it may be an underlying cause of POTS and CSF leaks. In terms of CSF leaks, I can say that there is an association in that patients with connective tissue disorders, potentially that may be a risk factor for CSF leaks. But in terms of POTS, do you have any thoughts on that?
Yeah, so there's definitely an association. It's, in our big pot survey, it's about 25 to 30%. That's consistent with what other sort of autonomic clinics have reported. So EDS in the POTS group, right? Our survey is not EDS based, so I can't tell you the numbers the other way, but there's an overrepresentation when you come at it from either side. The issue of causation is interesting, right? I find that the EDS community and patients in the community seem very certain that their EDS is causing their POTS. But the truth is that they're both syndromes, right? I mean, it's Ehlers-Danlos syndrome, postural tachycardia syndrome. We don't actually know exactly what's driving what, even within EDS and the family of EDS things. And if you were to, and I've been to EDS meetings and given talks like this at EDS meetings, and there's sort of this sense that there's in a hand wavy way, they'll explain, well, my ligaments are lax and the same thing's happening in the blood vessel and that's causing this and that and so on. And the answer is that might be true. But no one's ever studied it. And in fact, we actually have a grant proposal out to a couple of different groups to look at that, right? Because we could actually study physiologically, carefully study patients with POTS with EDS and patients with POTS without EDS and try and look at different aspects of vessel stretchiness or lack thereof and blood volume and things like that and see if the groups look different or not. But definitely an association, but not clear what's causing what and how.
Right. Okay. Sounds good. The next question is about kind of constant headache. So if someone has a 24/7 headache, worse when standing, reduces a bit when they lay down. I guess the question is, could this be POTS or could it be a CSF leak? And I think from my perspective, it's possible that it be both. Unfortunately, we do see patients that have headache even when they lay down. From a CSF leak perspective, I think probably you've seen that as well, Dr. Raj, but what are your thoughts on that?
Well, you've heard about going to the lion's den. Like, I'm not going to sit on a chat with you and tell you what's causing headaches, right? I mean, the reality is my approach is to get you to see them. I will say that it's unusual for headache to be the dominant symptom when POTS is really, when it's just POTS, let's put it that way, right? So do POTS patients have headaches? 100%, a lot of the time. Are the headaches positional? Not always, right? I mean, it's a potpourri of stuff. A lot of patients are diagnosed with migraines, not necessarily positional migraines. But I mean, if the headache's clearly positional, actually, in my mind, that does make me wonder more about, a CSF leak as a cause, as opposed to this just being, that most POTS patients have headaches.
Right. Thank you. The next question goes back to the EDS that I think we've already discussed the association there. And in terms of the vagal nerve stimulation device, there was a question about whether that's commercially available, I guess, in Canada at this point.
Yeah, so there are some that are. This particular one isn't yet. I think it's available in Europe. That way, I think they haven't fully gone to the FDA. Like, if we get this study underway, they'll support that with the idea of going to the FDA after for this indication. The standards are a bit lower in Europe in terms of having to show benefit, right? But you can get it in Europe. It's a European company too. There are probably at least a half a dozen companies that do different forms of vagal nerve stimulation. There is one approved, a Canadian company that has a device approved for long COVID. The approach is a bit funny, Let's put it that way, right? So you have to be careful with what you're stimulating and how you're doing it. And those are the things that we don't really understand, right? How much stimulate, where should you stimulate? How much should you do? Is more better, or is there an optimal level? And these are the questions still being sorted out right now.
Okay, thank you for that. The next question is actually quite challenging in that, patients that have a CSF leak and get it repaired sometimes develop a rebound intracranial hypertension. So they have kind of the opposite type of issue where, they have some degree of high pressure and their headaches are worse when they're laying down. And so the question is, if they also have comorbid POTS, what would be the best way to treat that? Because typically salt and volume will worsen rebound high pressure. So do you have any recommendations in regards to how you would manage the POTS?
No. I mean, the slightly longer answer is, and I have a few patients, I mean, most of my patients don't have intracranial anything. Of the ones that do, I'd say more have hypotension than hypertension, but there are a few that have hypertension, intracranial hypertension diagnosed. I think if they tolerate it, things like acetazolamide are used, and there's certainly there's a clinic in Texas that believes that everyone with POTS should be on acetazolamide. There's not really good data for that. But there are reasons to think it's an intriguing drug and one that we may want to study more in the future for POTS in general. But certainly in those with intracranial hypertension, I think we'd often recommend acetazolamide and deal with the consequence. That's the challenge of diuretic versus not. Yeah. So we want the volume, but we may want to alter sort of the CO2 and other things that cause vessels to squish and go from there.
Right. And we use it commonly in our patients with RIH. So, okay, sounds good. Someone's asking if you can share the name of your colleague in Ohio and they can get a referral there potentially.
Well, it's in Toledo. The guy's name is Blair Grubb, Grubb. And the answer is probably not, only because he's had in the past a 2-year waiting list, but I think he's actually trying to retire. And so I'm not sure if he's going to be practicing in 2 years. Now, having said that, I think he's trying to train someone, so hopefully there'll still be a clinic there. But yeah, he's had a big, clinical practice down there for some time.
Okay, that's great. And one of our pediatric neurology colleagues is asking if anyone has looked at chronic disease treatment and how that might improve POTS. Difficult study to do probably, but
what do you mean by chronic disease? Like
I think whether that be migraine or other sort of long-term conditions that they may have, for example, would that potentially improve their POTS as well?
I don't know that treating migraines is going to improve the tachycardia, but it certainly could improve their quality of life. Like I said, it's one of the things in these patients with a whole bunch of things is that there's often 1 or 2 things that are driving the quality of life. And so I've certainly seen patients that have excessive tachycardia that meet criteria, but honestly, what's determining their quality of life is their migraines, right? So no matter what I do, I'm not going to actually improve their quality of life tremendously because that's not what I do, isn't targeting the main problem. Having said that, I don't think this applies to migraines, but there's certainly reports of some patients with autoimmune diseases that, the treatments for a lot of which these days are biologics, right? Small molecule IBs and ABs, if you will. And in some cases, when someone's on an IB or an AB for, say, their Crohn's disease, they find that their POTS gets better, right? And this sort of plays into the whole autoimmunity playing a role in some POTS, and there's an association with Sjogren's and things like that. So sometimes the disease treatment may have an off-target beneficial effect, but I don't think if it's not that, just treating the comorbidity is not going to necessarily help with the tachycardia and other issues.
Right. Okay. Sounds good. There's another question, I assume for your clinic specifically, Dr. Raj, in terms of whether you take patients from out of province or if you offer telehealth.
So we do take patients from out of province with difficulty. So I usually will try and see if I can advise people locally, because coming from out of province is a major pain in the butt and expensive and stuff. But yeah, in theory we do. It turns out that the short version is, for a while we were doing telehealth out of province until we were basically told that we were idiots. In some cases, it's illegal for me to, these are things that we learned when COVID happened. I can see anyone from Canada if they come to see me in clinic in Calgary, and my license will cover me. But if I do a telehealth, the care is apparently delivered where the patient is, not where I am. So even though I'm in Calgary, if I do telehealth with someone in Montreal, I'm delivering care in Quebec. And so either the Quebec College equivalent, the College of Physicians and Surgeons of Alberta equivalent in Quebec, has to allow that, or I need to get a Quebec license, or I'm potentially guilty of a felony. And so there's some provinces that allow it within reason without a license. But then the provincial healthcare, like if someone comes to see me in Calgary, we just bill as if they were from Alberta and the provinces work something out magically. It turns out they won't do that for telehealth. And I'm not sure why. I'm not sure if it's a conscious decision that they don't want telehealth, or if it's more just no one's really thought about it before COVID and they never really fixed that problem. So that's a very long-winded way of saying telehealth. I do a number of telehealth visits, but people have to be in Alberta, right? So if they're from out of province, those have to be face-to-face visits.
Thank you. That's helpful. So maybe we'll just take a couple more questions for the sake of time. So the next one is whether POTS might interfere with sealing of a leak. So if someone has had a leak, if they have POTS, are they more likely to develop another spinal CSF leak?
I don't have good data on that. My guess is that it's probably going to be unrelated. I think Ehlers-Danlos syndrome is more likely to have issues with leak patch integrity. Let's put it that way, right? I'm not ever sure if the problem is the patch fails, or is it more like whack-a-mole where one leak pops up, you fix that, and that one might be okay. But then, if the issue is tissue integrity, that a leak pops up sort of down the street.
Yeah, I agree. I don't think that there's an association either for that. And then the last question I think we'll take would be whether you use Florinef or not in your patients.
But for those that don't know, Florinef is the real name. That's a brand name. The trade name is fludrocortisone. It's a fake version of a hormone that we all have called aldosterone that tells the kidney to hold on to sodium, right? So I view it as the next tier of my salt and water strategy. We give water to expand the blood volume. We give salt or sodium to get the kidney to hold on to some of the fluid. And the fludrocortisone or Florinef is designed to tell the kidney to hold on to the sodium to hold on to the fluid. So with that, no, I don't use it very often. I used to use it more actually. And since I got more aggressive, instead of just telling people to take a lot of salt, I got more prescriptive and aggressive about being very specific about how to do that. I find that I haven't had need to do it as much. The challenge with Florinef is that it might be safe, right? I mean, acutely, we know it doesn't cause major problems. But it's a cousin of a steroid, right? It's a cousin of cortisol. It's modified. It's a modified cousin. And while it might be safe, we still don't love the idea of taking someone who's 18 or 19 or 20 or 25 and potentially subjecting them to, a steroid or a steroid cousin for 40 or 50 years.
Mm-hmm.
I'm less concerned about, and again, there's not good data either way. I want to be clear, there's not data that 10 or 15 or 20 years of Florinef is going to cause horrible things to happen. But we know that's true of cortisol, right? Or prednisone and other steroids. And so I think people just have hesitance to use that in the long run. Are there people that are on it for years? Absolutely. It's sometimes needed. So I do use it, just not as commonly as some of the other drugs we've talked about.
Okay, that's great. Thank you very much. I just want to, again, thank you, Dr. Raj, for this excellent presentation and answering all these questions so patiently and going over time. We really appreciate you being here today. And again, thank you to Spinal CSF League Canada for organizing this event. A recording of this will be available afterwards on the Spinal CSF League Canada website. So thank you again, Dr. Raj, and thank you everyone for attending. Have a good evening, everyone.
Thanks for having me.